I think we'll wait for Samah to introduce you first. Yeah.
Sure.
Just a second, please.
Then we can do mine if it's possible.
Okay. Now, Dr. Ahmad Sherjil, a consultant neonatology at Victoria Hospital in Scotland. He will, his presentation today is about lung ultrasound integrated clinical decision making in neonatal units. The ultrasound is getting a lot of popularity in UK, in Europe, in the USA, and in Egypt as well recently. Dr. Ahmad will highlight this important issue to help us in diagnosis and decision making. The mic is yours, Dr. Ahmad.
Greetings, good afternoon, Assalamu alaikum, Professor Tawfiq. Thank you very much for giving me this opportunity and this very kind introduction. Yes, it's an honor speaking on this forum, but I assure you, you have made the right choice by letting me speak on this topic, which is very fast emerging, and it's increasingly becoming part of neonatal management and decision making, which is evidence-based and safe and yet very timely. So I'll speak today about the integration of this bedside non-invasive investigation modality, the lung ultrasound, which is part of POcUS point of care ultrasound scan in clinical decision making in neonates. So usually I would speak to people who have a special interest in scanning and stuff. I think there's a mixed skill people listening to this. So I thought it would be worth going through a quick, to the point, brief introduction to the lung ultrasound scan, so that we have an idea, everybody has an idea of what I'm showing in the video clips as we go to review the clinical scenarios here. It's always a good idea to remind ourselves how to score what zones and stuff. So it'll be a quick initial introduction, and then I'll move on to the actual presentation of taking you along in a ward round in an NICU. So lung ultrasound scan as part of the point of care ultrasound scan is a quick, reproducible, bedside, radiation-free investigation, and it's a little bit different from echo and cranial ultrasound, which we are very familiar with, in the sense that this scan depends on the interpretation of artifacts of the ultrasound beams. So what I would be referring to as lung parenchyma is actually artifact created by other structures. So how do different things appear in a lung ultrasound scan? So an oversimplified description here is, so you've got black images and white images, and then you have shades of gray. Something completely black, very hypoechoic, is fluid or blood, which is fluid. And a bone shadow, not the bone, the shadow of the bone that just looks black, which means either it's fluid or it's nothing. White, which is hyperechoic, would be clotted or hemorrhagic blood, but more importantly, the white appearance comes from fluid-air interface. And something very mandatory to lung scan is the anatomical area where the two pleura, visceral, and they slide over each other. So as things go more ischemic, they become more echoic. As they go more vascularized, they're more hypoechoic. So here is a comparison of if you can see my pointer, you're seeing a usual anatomy atlas photograph of the chest wall that shows the chest wall, the skin and the subcutaneous tissue. Then if you follow my arrow, ribs, and under the ribs is the lung parenchyma. However, if you look at the sonotomy here, you're going to see the superior rib, inferior rib, and the area between the two ribs, which represents the intercostal muscles. But then under the intercostal muscles is an area which I'm going to refer to as lung parenchyma, just for the ease of description. But actually, this is all artifact of the pleural appearance. So let's have a look at the video clip here and try identifying the structures. So right on top is the abdominal wall, the subcutaneous tissues, and then you're seeing 3 rib impressions here. So this is a rib image, that's fine. But what you're seeing under the rib is nothingness. So this black appearance is where the ultrasound is blind and cannot see anything because the rib is absorbed, reflected everything. Between 2 ribs, you're seeing intercostal muscles. Now, what's under the intercostal muscle is the important thing. That's the interface where you're seeing the 2 pleura, visceral and parietal, sliding over each other. And if you look down where the pointer is going, there is another horizontal line which doesn't exist. It's an artifact. It's a reverberation of the pleural line, the actual pleural line. And between these 2, you're seeing some more horizontal lines. These are all artifacts. These are all reverberations, and they have a meaning. They are called the A lines. Now, originating from the actual pleural line are car beam-like comet tails, which are oscillating as well. They originate from the pleural line, and they go all the way down to the computer screen, all the way down. And they're moving. So these vertical ones are called the V lines. The probe you're seeing here is an upcoming probe, increasingly being used. It's referred to as the hockey stick. Very recommended. Although you can use other probes as well, but that's not the scope of my talk today. Where you put the probe on, roughly. So you've got 2 sides, right and left. On the right side, the upper is referred to as zone 1, lower zone 2, and 3 is the lateral. So again, it's not the scope of my talk today to go into detail, but these are the 3 zones on one side, 3 on the other. So you've got a total of 6 zones, and that's one way of doing it. Some people do 8, but that's the more happening more. Well, that's what I do. So looking at this image, you're seeing lovely shiny pleural lines in 2 intercostal spaces, and you're seeing some B lines overlapped by A lines. So this is the kind of thing you would score as a 0. In this image, you can appreciate that the vertical lines, the B lines, have gone a little bit more than 2 to 3. So in one of the intercostal spaces, they're probably 7 or 8. But they're still not hitting each other. They're not coalesced. They're not merging into each other, and you can still see B lines. So this is the sort of image where you're getting more fluid in the lung, interstitial fluid, and this image is scored as 1. So you got 0, 1, 2, and 3. So this would conform to score 1. Here, I'm sure you have appreciated already. It's pretty easy to fine interpret that the B lines, the vertical lines, have gone into each other. There, it's all a whiteout, and you cannot count the B lines, and you cannot see any A lines here at all. So that's alveolar edema, which clinically sometimes can correlate with RDS. So you get a score of 2 here. In this image, go straight to the pleural line here. It's all interrupted. It's thickened. It's shredded. And under this interrupted pleural line, thickened interrupted pleural line, you're seeing subpleural echogenicities. So these bronchograms, these echogenicities often represent a collapse-like situation. So collapse consolidation. That's what an oversimplified meaning of these is. So this sort of appearance would get a score of about 3. So once you have scored all 6 zones, the lowest can be 0, the highest can be 18. Mild disease, it said 1 to 6 would signify a mild disease, 7 to 12 moderate, and above 12 score would be severe disease. And this burning question these days, all colleagues keep asking, a very interesting thing. Does this baby need surfactant or not? So if you're getting a score of 8 or more in a less than 32-week gestation baby, that's very suggestive of an indication for surfactant. Having said all this, it's really important. The most important thing about point of care scan is integration into the clinical situation. So what guides you, what leads the whole situation is your clinical decision, and the ultrasound, it has to go along what you're perceiving and what you understand. This gives you evidence. It does not deny, and it shouldn't be taken as a final word. So the clinical assessment matters here. So it's not like you have a score of 8 and go for surfactant. It's something that we're going to see in my presentation just now. So the topic now is lung ultrasound integrated clinical scenarios, where a busy day is made easier and safer by using the lung ultrasound scan, because it gives you evidence. You make a decision quicker and earlier than others, but it's evidence-based and it's safer, and your day gets far more organized than when you're not using it. So I'm going to share my experience of integrating scan in everyday management. So it's not about making a referral to radiology. It's not about making a referral to cardiology for hemodynamic assessments and all that stuff. So I have not, what you're going to see is something that I've not created any slides. I have endeavored to recreate a busy day in NICU by demonstrating anonymized but original X-rays, patient entries, alongside the original lung ultrasound video clips of my own patients. So these are exactly the situations I reviewed them in, using the scanner to make timely decisions, yet evidence-based and safe. So let's challenge and raise the impression of scan a little bit above the reputation that ultrasound is a time-consuming referral, and allow me to take you along to one of my busy days in a NICU. So as I walked in to the handover, turns out that the most important person for the handover, the night registrar, is stuck with the baby waiting for an X-ray, because there is this umbilical line that needs to be X-rayed, then adjusted, then X-rayed again. So as a matter of priority to get her, I went upstairs, scanned. The tip here, you can see here, is a little bit beyond being acceptable. So we moved it live, real time under the scanner, and then the tip was accepted to me. The line was secured. Handover happened in time. Night team was able to go home. So after the handover, having prioritized my patients, I walked into the ITU as the registrars and the rest of the team were preparing for the ward round, but I prioritized some patients. So the charge nurse takes me straight to this little cute boy who was 24 hours old, was having a cuddle with mom. And there was no increased work of breathing any more than before. There were no incidents of desaturation, color change or anything. The question was, the oxygen requirement is slipping up. So I reviewed, found out there was a 34 plus 2 weeks gestation, 1880 grams, elective section baby for tailing growth, mom had a full course of antenatal steroids and had been on CPAP since admission. Good guesses. FiO2 from admission had been 21%, and a chest X-ray taken soon after admission is what you can see here. Okay, ground glass, streaky, nothing too exciting here, and so something in keeping with this gestation here. So this is an original anonymized photograph of the patient's entries. Here you can see where the arrow is, inspired oxygen 21%, and it was no incidents, but it was creeping up. It was 33% when I ish. But then the impression and the pH here all along was okay. Even later it was all fine, but at that occasion, 7.25 mild respiratory acidosis, a little bit more than before. So the impression was that we had the baby out for a cuddle on a CPAP and stuff, so that being unsettled is needing a little bit of oxygen, and we'll go back and we'll settle the baby, will be fine. I was, because lung scan is so handy, no issues, no radiation, so I scanned this baby just for my satisfaction. And if you look at the right side, first things first, identify the ribs here, identify the pleural line, and I'm going to run this. So what you're seeing is so on the right side, you're seeing a thickened pleura with lots of B lines, but they're not merging into each other. So you're seeing a thickened pleura with sub pleural echogenestes. So move on to the R2, which is right lower zone. Again, a similar sort of picture, but a little bit better pleura here. Lots of B lines, and then the lateral side moving. So I made an impression of what the right side looked like. Moved onto the left, which took less than a minute. And here you can, even before I move the slide, you can see this is different. So it strikes at you, the image, even if the nurses standing by the side didn't know how to scan, they could say that this is completely different from what they had seen on the right side. So I'm going to run this here. And again, first things first, identify the structures, ribs, and then pleural impression. And then our artifact, and all you are seeing are horizontal lines, A lines. There's no B line here. And a closer look would also show you that there is no pleural slide here as well. So you need a bigger image to be certain of this, but complete absence of B lines, and all of a sudden, all A lines. There's something called the M mode, which in an air leak has a characteristic appearance. So the M mode here is called the barcode sign. So that showed, the M mode did show a barcode. So this was a pneumothorax, a tension pneumothorax, identified within seconds. So I just moved the probe from right to left, and this nurse standing next to me said, this is different. And this different is how a pneumothorax appears. So as I informed the team to get ready for, we did an intubation and chest drain, and the lung expanded. And as team got busy with this, I moved on to the next baby, two babies who needed to be promoted. So in a busy NICU day, there are lots of babies who could be promoted, but then, and it matters, one free cot matters. But then you need some evidence and some courage to discharge them. But in a conventional way, somebody may take more, another 6 hours, another 1 day. So I feel that if the scan can give you even one early hour of being discharged or being sent out of the ITU into SCOBU, that matters. It matters to organizing the day. So the charge nurse asked me to review these two little guys. One was 13 hours old, a term baby, good weight, had been back and forth from the postnatal ward, because the minute he would go to postnats, they would bounce the baby back for intermittent and / persistent grunting. So the second time he came in, his pH was a little bit, it was 7.2, mild respiratory acidosis with the PCO2 of 7.8, and not requiring any extra oxygen, but he was put on flow, and then it was about 4 hours, maybe more, when I saw him. So in a more traditional, conventional way, you would do it, because there was a so-called respiratory support for 4 hours or more. So you would do an X-ray, keep the baby on observation, and send him away when you think it's safe. All I did was scan him, and you can see here in the moving video clip some shining, nice thin pleural impression. You're seeing lots of B lines, yes, but you're also seeing lots of A lines here, which indicate good alveolar recruitment. So like in a real situation, no time wasting, move on to the other zone. Again, some increased B lines. Yes, it was a wet lung off TTN, but then lots of A line, good alveolar recruitment on the left side here again, if you see on the L3 image. On the right side, again, a similar message that this is a very well recruited lung. Yes, it's a little bit wet here, but nothing really to demand respiratory support. And so if you again look at the first slide, there is this area where you're seeing the vertical kind of hitting the horizontal. So this is called the double lung point, and double lung point is said to be very suggestive of TTN. So this baby had a TTN. Now I had an evidence, and I sent the baby, was straight away discharged back to be observed with the mom. And in hindsight, never looked back, was later discharged home. The other one was a meconium aspiration syndrome girl who was 2 days old. So have a look at the X-ray. It looks exciting. If you look at the pH here, initial after birth pH 7.1 with a double figure PCO2. So a decent bit of respiratory acidosis. So this baby was 48 hours old when I saw her. And at the time when this baby was admitted, if you can follow the arrow, see the oxygen requirement, it was pretty high. And when I reviewed the baby, it was still 37–38% documented here. And this baby's initial scans, if you look at the moving clip here, identify the structures clearly going straight to the pleura, thickened pleura, all shredded, interrupted, lots of bronchograms, lots of collapsed areas. The second one, again, look at the degree of brokenness in the pleura, and lots of V lines, but lots of collapse consolidation. So this is in keeping with meconium aspiration syndrome. And so this was the left side. On the right side, again, a similar message. And at that occasion, I performed, at the time of admission, I performed an echo as well, and you can see a blue duct here reversing. So that there was evidence of PPHN. So this girl was managed, but then she was 48 hours old and still on CPAP and still on needing all the oxygen. Clinically, there was this impression of her getting better, but how would you, in a more orthodox way, you would have waited for another day, at least another 12 hours, at least another 6 hours. I scanned her, and have a look yourself. See the degree of horizontal lines here. It's so reassuring that now she's no collapse visible. Look at R2, again, lots of horizontal lines, good alveolar recruitment, nice and thin pleura. Okay, so the pleura is in some images is not very thin, but then it was an insult that would have taken some time. But the message here is that the lungs were looking reassured, very reassuring. So I changed entire management. I, in fact, promoted her straight away out to special care with a little bit of oxygen. And still, even without the scanning evidence, 7 days later, he was, my colleagues, if somebody had this X-ray done, because he still wanted to know what's going on. So you can see it's all fine now. And then she was discharged. But I had this information 5 days ago. And that made a difference to the management, to a day when I was able to free a cot. And then moving on to this little boy whom I had extubated the previous night. So this really sick baby, twin 1 TTTS, twin-to-twin transfusion syndrome, donor, 28 weeker, 1180 grams. So I removed his tube, and I came in to know. The nurses were saying, "Do you think he's working? He's recessing on CPAP, and a CPAP of 6 centimeters, and his FiO2 is the same. The gas is fine." But look at him, he's recessing on CPAP. Is he heading towards an extubation failure? So, and clinically, it did seem very possible. So I did a scan, And you were expecting a sick lung here. It was a twin-to-twin transfusion syndrome baby with the background of pulmonary hemorrhage, pneumonia, chest strains, and all whatnot. So you're not expecting a good lung here. So what you're seeing here is a very interrupted pleural line. In fact, there are lots of bronchograms, there are lots of subpleural echogenestes there, and there is this appearance of white and black. So echogenestes overlying hypoechoic areas, which is suggestive of consolidation pneumonia rather than a simple collapse. However, looking at all 6 zones, I've shown you just 2. And keeping the clinical picture in mind, I felt that the predominant change was of collapse. So combination of things, but the predominant thing was a collapse. Therefore, okay, 24 minutes. So based on the scan and my clinical assessment, I decided to not to worry about reintubation just yet. And I thought, let's go up on the CPAP pressure first, which was 6 centimeters, and I pushed it to 8, which was completely based on the scan. And having looked at these bad lung videos, it was hard to believe that after increasing CPAP, a little while later, I scanned the baby again and see how nice the pleura is looking. You're seeing some horizontal lines straight away. R2 again, yes, it's full of some other pathology still. But I wasn't expecting things to just disappear, but the alveolar recruitment, inflation of lung is remarkable here. So and similar happened on the left side here. And I do understand on L3, which is moving now, you're still seeing a lot of pathology there, which was nothing unexpected, no surprises. But this is how lung scan can enable you to do a very accurate sort of troubleshooting, and then to be able to bring this evidence to your team and say, okay, don't worry, we are heading in the right direction. We're not heading towards a reintubation. Is pretty remarkable. And in hindsight, this patient everything happened to him, but he was never reintubated again. And a burning question, a favorite question for most of our colleagues, for me, will this baby need surfactant? So this gentleman was 6 hours old, baby boy, 29 plus 4, 1390 grams. And he had antenatal steroids, magnesium sulfate, and has been on CPAP. But the problem was that this 29-weeker, his work of breathing never settled. His oxygen requirement was persisting. And as you can see here, where my pointer is, it says 30% of FiO2. And the pH was a little bit worse than before. So you have a 29 plus 4 weeker who's working hard despite his CPAP. His gas is 7.2, which is a little bit more acidotic before, and his FiO2 is persisting at 30%. Well, and you're looking at the X-ray here. Okay, it's not terribly ground glass, but still, putting everything together, the word surfactant, yes, it was required, or at least he's heading towards that direction. It looked like there was a situation. So I knew that the X-ray was not going to do much about this, so I scanned him. And if you look at L1, which means left side, and it's upper anterior, upper, not necessarily anterior. So you're seeing a pleural line which is thickened. There are no subpleural echogenestes, not many, but the B lines are pretty much coalesced. And this, yes, it does show surfactant efficiency. Move on. L2, again, a similar sort of appearance. However, you do see some horizontal lines here. So we're going to move on, and this is as quick as I did in real time. So on L3, again, similar message. In fact, a little bit more thickened pleura with coalescing B lines. R1, similar message. Have a look at R2. So here, yes, lots of A lines. However, there's a clear area of good aeration here. This is not a uniform finding. The finding of alveolar edema score 2 is not uniform here. You have areas R2 and R3 written here where you're seeing far better alveolar recruitment. In RDS requiring surfactant, it has to be a uniform appearance of alveolar edema all across the chest. So against all expectations, I decided not to give this baby any surfactant. We just persisted with our CPAP thing. And in hindsight, this baby never needed surfactant. This is not the scope of my talk today, but just a quick glance. You can see peristalsis here, and there is something to say about whether this is a CPAPTEMI or not. Should be SART feeds. I couldn't hear vowel sounds, but can I see peristalsis? So I'm going to say just this and move on because this is not what we are discussing today. But again, this is part of lung scan. So accidental extubation is a big problem in every way. Some places you don't want accidental extubation. So a nurse comes to you, says, I think this baby is going to, the tape is loose, it's mobile, the ET is mobile, it's going up and down with movement, and what are we doing about it? So I found the tape okay, but yes, with the movement, opening of mouth and movement, I could see the ET became more visible and invisible, kind of causing a fright that it may come out. So what was the way to make sure that it's nice and stable in the trachea and not too far to in, and it's not, and the tip is not fluctuating in its position? So scan is the best. So here, this is not the baby. This is just to enable you to see what I'm just going to show you. So what you're seeing here, if you can see, follow the finger tip, you're seeing the tracheal rings. So yes, they are incomplete in a baby. So those incomplete tracheal rings are apparent here. And this big blood vessel is the arch of aorta, the origin and the arch of aorta. And in this colored one, again, you're seeing the tracheal rings, and you can see the flashing color in the arch and the origin of the aorta here. So where the finger is now, that's where the ET, when you angle the probe upwards, you're going to see ET as two parallel lines visible here, if there is ET. So this patient doesn't have an ET. But when I'm going to show you the next image, I hope you'll be able to identify the two parallel lines and the distance from the arch of aorta, because that arch of aorta is the reference point for cadena. So you measure the distance from arch of aorta to the lower end of the ET. So this is a 25 plus 2-week baby, 840 grams. He had a tube in, and it's always a problem, avoiding stabilizing the tube. So here, what you're seeing is, let's identify a few structures here. So these big ones are, this is the spine, and tracheal rings, and these two parallel lines, which will be, so you can now very clearly see two parallel lines, and you're seeing that despite all the movement, they're pretty stable inside the trachea. They're not popping in and out. So I knew that I don't have to worry about how the tube is being secured, and the distance from the pulsating aorta is pretty decent as well. And so if you're really adamant on measuring it, you can see the two parallel lines, they finish here, and there is this aortic arch and the origin, and you can just freeze it, measure it. But even without measuring, you can see that it's an acceptable position, not too deep, not too high. So this is the last one. So here comes a complicated sick baby, 15-year-old, a patient of twin transfusion syndrome, brother of the one I showed earlier. So he had everything you could imagine written in the neonatal book. A very, very bumpy time before he finally stabilized. in the NICU. So he, at one occasion, you can see the X-ray here. It does suggest, so it suggests collapse, consolidation, a bit of effusion. But if you look at the scan, it tells you a far more detailed and a far more accurate account of what's going on here. So this is a costophrenic angle on the right side, and what you're seeing is a shredded pleura here, where the subpleural echogenicities are more dominant than the pleura. There's no pleura here; it's so damaged, and the echogenicity the echogenicities are so hyperechoic that I'm sure it will remind you when I said white is for blood, clotted blood. So this is pulmonary hemorrhage, but more in addition to that, if you look into the pleural space here, it goes the space, you'll see this one. Yes. So you're seeing a collapsed bit of lung here with lots of hemorrhage inside it. So it has also almost become a tissue, visible as a tissue to the ultrasound. Usually the scan sees the lines, but here it's so kind of solidified that there's so much of blood there. So lots of hemorrhage, but also see the fluid around it. There is so much of debris floating around it that it cannot be a straightforward pleural effusion. So this suggested blood clots. There was a chest drain, so I didn't think all this debris floating could just be blood. I mean, bottom of the differential diagnosis, but could it be lymph from the lymphatic duct that might have gotten damaged when a chest drain was put in? But also, it could be infusate from a poorly placed long line, a tip that had migrated. And in the end, it did turn out to be, so we stopped the PN and removed the long line. And I did aspirate about 20 mils of very lymph infusate looking fluid from this area under ultrasound guidance. And the ventilator settings went down, lung kind of opened up, as you can see here, compared to the earlier one when it was all white out. And ventilator settings, the low pressure, the FiO2 got better, and it was a marked progress. So having said all this, I'm going to summarize by saying that yes, scan has a recognized role when you call somebody from cardiology or radiology for a hemodynamic assessment. Yes, it has a role when you have no option and you do it as a matter of urgency to see a duct-dependent lesion. That's fine, but it has an even bigger, more emerging role in your day-to-day clinical practice and a part of your ward round. It does help you make your day better, safer, evidence-based. And I believe that the diversity of application it has is we're becoming more and more aware of it. And there's a lot of potential more indications that are coming up that can help you make your day, as I said, easier and safer. So that's all I have to say. Thank you very much for your patient listening.
Thank you very much, Dr. Ahmad, for your excellent presentation. But let me ask you a question.
Sure.
In the old days, we knew that the ultrasound is operator dependent.
Sorry?
Ultrasound is operator dependent. Ultrasound is operator dependent. How can you minimize the variations in the operator while using the ultrasound?
Okay, so the lung scan has a steep learning curve, but that doesn't deny two very important issues here. So first of all, it has to be somebody who's doing it needs to be trained. It's not as horrific as learning to echo. The rest of the point of care scan has you need lesser time, but you still need to be trained. The youngsters and the new people coming in, colleagues, it has to be a supervised training thing, and then you have to have your own standardized protocols in the unit. So because this issue of being operator dependent, this is the only way that not everybody has to hold it, and also that when you're scanning, you need to be clinically strong. So it's not for a technician. POcUS is not for a technician who tells you that this is the side of PDA and I'm scanning a radiographer, I'm leaving. So this is for a clinician. And the other thing which is important here is that, you see, technology every day is improving. So I remember the scanners, they were vague and completely operator dependent, and it was more of one of my mentors' eye to see something important in the to be able to recognize the correct findings. Today it's different. Now we have come to a stage where I'm going to trial a handheld ultrasound scanning probe very shortly. So it'll be like a pen in my hand. So that big machine attached to the probe and the wire, and you drag it and you turn it on, it takes time, and you fit it into that crowded space, and that's going to go away soon enough. You'll have a pen-like thing in your hand. On your iPad, you'll see something, and so this progress in technology is making it very easy to see images, and it's minimizing observer bias. But yes, training, the right equipment, they are needed to minimize this.
I understand, if I'm correct, is that the lung ultrasound is as accurate, or how far is it accurate as CT? I mean, the sensitivity of the ultrasound, lung ultrasound versus generally.
So lung ultrasound has its place. It has some fantastic things that CT, MRI, and X-ray, they don't have it. But in no way are we doing away with it. It doesn't mean the X-ray is not needed. It doesn't mean CT scan is not needed. It has its own indications. But yes, you're right. Increasingly, it's taking over invasive radiology. So X-ray, CT scan, there are increasing occasions when the scan is replacing them. But it doesn't completely replace them, because there will be indications for CT scan. So it's emerging, it's replacing, but no one has ever said that it has replaced, or the CT will have its own indications.
Okay, but I understand that you can pick all the lung pathologies by ultrasound. Am I correct?
I would say no, because this is a blanket statement. Not all. There are some issues with the lung scan, a fundamental problem, and the problem is that you're looking at an artifact. You're not looking at an actual structure. You're not looking at lung parenchyma. So it's just an artifact which, with experience and RCTs and stuff, they've gone very accurate on interpretation. So if there is a lesion deeper in the parenchyma, it's not going to pick it up. It will still say that there is an area of good aviation. So I thought, okay, this must be a CPAM, that all of a sudden there is some aviation here, or an air leak or something. But if it's a deeper lesion, because it hits the pleura and then it's the reverberation and pleural sliding and stuff. So that's one problem. And the ongoing issue with the scan is that it's no good tool to tell you about the inflation. So if you have put somebody on a ventilator, you scan him, there's no way to say how far are you overinflating, because you're going to see lots of alveolar recruitment. That's fine, but is it crossing the line? It doesn't give you any idea. So it has its limitations. So that's why I'm saying you have to be a clinician on top of the clinical situation first, and then make use of it.
Okay, thank you very much indeed. Thank you very much. Thank you very much.
My pleasure. Thank you for calling me. Thank you
very much. And now our My dear friend, Dr. Madhat Aizat. Dr. Madhat Aizat is well-known and sincere friend for me, actually. I usually ask him most of the things, most of the problematic patient neonates I have in Cairo. He helped me to put up my protocol in my neonatal units, even sedation, even whatever basic knowledge I did what he told me to do, actually. Thank you very much indeed. Dr. Madhat Aizat is a consultant of neonatology and honorary section at Aberdeen University. He will talk us about the recent or the most recent guidelines or protocols for hypoxic respiratory failure in term and near-term infants, stepwise approach in management. It is just, I understand that it is just recently delivered or recently issued a few days ago. That's why we have changed the topic, because it is an important item for us. So Dr. Madhat, the screen is yours, and I hope you can share the screen or with the help of Dr. Ahmad Sherjil.
Okay, thank you very much, my dear friend, Major General Professor Sameh Tawfiq. Sabah al-Khair, still Sabah al-Khair, it is almost 2 o'clock here in Scotland. It's a pleasure actually to get invited to this pediatric conference. And in fact, I watched some of the lectures yesterday and today, and was impressed with the quality of the presentation. I hope I wouldn't get any technical problems because I'm not a technical person. So I will try my best to see what I can do. Can you see it now? Can you see my presentation?
Not yet.